Have Dr. Michelle Hagenbuch. I hope I pronounced that correctly. Hagenbuch, I'm sorry. I was halfway there.
Close enough. It's been slaughtered worse, trust me. Well, good morning, and I appreciate the opportunity to come here and talk with you all today about COVID-19 specifically in rural South Carolina. I've been in private practice in Lawrence County for 25 years. My practice consists of myself. I'm an independent practitioner with one amazing nurse practitioner and an excellent support staff. Let's turn back the clock to the spring of 2020.
Will you pull that microphone a little closer to you?
Is that better?
Yes, ma'am.
Okay.
Thank you.
Okay, how's that? All right. Let's turn back the clock to the spring of 2020. At that time, we were seeing dramatic number of hospitalizations, ventilator management, and deaths, especially in elderly and those with comorbidities. I am an outpatient physician. My discussion is limited to outpatient therapeutics and practice. At that time, outpatient guidance from CDC, DHEC, and various medical organizations recommended symptomatic care only and go to the hospital if you just couldn't cope at home. I found that unacceptable. Practitioners in my community were doing some televisits. I found that a little bit difficult to evaluate someone's pulmonary status over the phone or over a televisit. I may be old-fashioned, but I still like to examine my patients. I began doing research not only in the United States, but on the international framework as well, and I read the entire study, not just the abstract, which is kind of the Cliff Notes version of a medical document. During that time, I found that there was a lot of interesting things. We can discuss that later. But so because of this, we chose to change the way we practice in my office. I actually was semi-retired. I came out of semi-retirement. My nurse practitioner quit taking a day off. We pretty much worked from 8 o'clock until the last patient's seen and through lunch if necessary, seeing between 50 and 80 patients a day. Not just patients within my practice, but unfortunately patients throughout the state of South Carolina who cannot manage to find a physician that will actually see them, evaluate them, and treat them. Well, we don't have a strict protocol, but what we did, if patients had mild symptoms, we treated them symptomatically. Then we recommended they be reevaluated in person in 2 to 3 days. If their symptoms worsen, we then discussed with the patient the options of zithromax, steroids, hydroxychloroquine, inhalers, aspirin, as well as what I call immune support, which is vitamin therapy. Also, we told people not to lay around, get up and move, exercise those lungs, don't get a secondary pneumonia. We saw them back every 2 to 3 days until they either required hospitalization or got better. Now, fortunately, with the addition of monoclonal antibodies, that has changed a little bit. We are using more monoclonal antibody therapy over the last few weeks. There is some not resistance, but difficulty getting patients these therapies. In my patient population, I've seen between 1 and 5 days that it will take to get someone in to get therapy based on bottlenecks of the number of doses. They can only give so many doses in a day. And also, these people, they're taking all comers throughout the community, so they do try and risk stratify to give it to the sickest patients first, which I feel is appropriate. Let me make it clear, though, 75% of the patients I treated required only symptomatic care. Of the over 700 COVID patients I cared for, only 2% required hospitalization, 0% required ventilator management, and 0% died. Once again, I will say that 75% required only symptomatic care. Of the over 700 patients I treated, only 2% required hospitalization, 0% required ventilator support, and zero deaths occurred. I'll put those numbers up against anybody.
Mr. Chairman.
Oh,
My passion, can I continue?
yes, ma'am. I thought you were.
Well,
I thought you were stopping for a
okay.
second. Go ahead. Continue, please.
My passion stems from embarrassment. I'm embarrassed about my profession's poor handling of this medical situation. I'm embarrassed to see doctors abandon their patients. I'm embarrassed to see a medical illness become a political pawn and a reason to foster more division. The genie is out of the bottle. We cannot cram it back in as much as we would like to. We have to think about the fourth quarter and what the end game is, as well as what we're playing right now. Now I'm done.
Thank you. Thank you for being here in your testimony, and I wrote your percentages down, but I'll yield to Senator from Orangeburg. Senator Hutto, you have a question?
Yeah, I do. So is the point, I mean, are you telling me that somebody is restricting your ability to practice?
I fortunately am an independent physician. I am not employed by a hospital system. However, several of my colleagues that I've spoken with said that they have been told that there will be disciplinary action and possible firing if they go outside of their protocol, and specifically pertaining to ivermectin and hydroxychloroquine.
Right, but I mean, that's what happens when you work for somebody.
Right.
Right, you got to obey the boss's rules. And if that's
Well,
the boss's
unless you're
rules-
your own boss.
Exactly, and you are your own boss.
Yes,
and
I
so
am.
That's my point, is that nobody is restricting your ability to practice medicine and prescribe for your patients whatever therapies or drugs that you want to.
That's true. However, I have had one pharmacist on CVS in Simpsonville, South Carolina, that refused to fill a hydroxychloroquine prescription for me just a week ago. So, unfortunately, that pharmacist also inferred to the patient's wife that I was trying to do harm to him. Fortunately, she is a nurse. She was there for the evaluation and was 100% on board with the therapy that we had recommended. We had just
I assume
come
they
with
got it
together.
filled somewhere else, right?
Excuse me?
I assume they got it filled somewhere else.
Yes, I recommended that they go to another
Sure,
pharmacy.
so I mean, basically, the treatments that you have chosen for your patients, you've been unrestricted, and the medicines that you have prescribed have all been filled.
However, I will say that early on, I would receive patients that would come back 2 to 3 days later for repeat evaluation that would have a handwritten note from the pharmacist say that they refused to fill the hydroxychloroquine. So this was 2 to 3 days later. The pharmacist did not notify me. We live in a rural community. There is an educational gap, and the patients didn't know what to do. So they just came and brought their note to me 2 to 3 days later. So that, pushed back the therapeutics. And I guess the biggest thing I've seen with this is the earlier the treatment, the better the result. So from that standpoint, I would say I may not be impeded, but my patient care has been impeded.
Well, I guess my point is this. I think it'd be bad for us to tell doctors how to practice medicine. I think it'd be bad for us to tell pharmacists how to practice pharmacy. What is it that we need? What is it that you think we need to do? I mean, if nobody's restricting your ability to treat your patients as you see fit, and all your patients have gotten the treatment that you think they should have, and you've demonstrated you've got wonderful results, what is it that are you asking us to do anything?
Yes, I think that there needs to be some changes that practitioners, even if you work for someone, need to be able to practice medicine. I don't know if that's the purview of this committee or this board. I don't know. I'm not a politician. I'm a physician. But I think that if your livelihood, if you don't mind me asking, what do you do?
I'm a lawyer.
You're a lawyer? Okay. So if you were not allowed to prosecute a certain case or, say, do pro bono work, then you would have the option to leave your
I
livelihood.
could leave my law firm and go to another law firm.
Right. What if that other law firm had the same issues?
Well, look,
The same
I mean,
requirements.
that gets back to my point. If you choose to be employed by somebody, you got to follow their rules, right? If
Even if it kills people.
well, you haven't demonstrated, to my knowledge, that anybody's killed anybody.
Well, let's see. Let's talk about that. Okay, these are DHEC numbers. Where is that? Excuse me, let me get my other sheet of paper.
Senator from Orange.
Mr.
While
Chairman.
Dr. Hagenbuch is referencing her materials, might I just share a point of embarrassment? Dr. Hagenbuch expressed a point of embarrassment about the state of medical care delivery right now. I'm going to express my embarrassment as just having met Dr. Hagenbuch a few hours ago. I thank you, Dr. Hagenbuch, for coming. I thank you for your service to the citizens of Lawrence County, and it sounds like maybe every other county in South Carolina. I think you told me maybe states of Georgia and North Carolina as well. There's some great testimonial to the fact that you are seeing a 50 to 80 caseload workload per day and demonstrating the data of efficacy and success that you are. So On behalf of the committee, thank you for appearing in person as well. Mr. Chairman.
Yes, sir.
As of, these are numbers from South Carolina DHEC website, 9/19/21. The number of tests in South Carolina for COVID-19, 10,588,960. Cases, 832,466. Hospitalizations, 28,089. Ventilators are not listed. Deaths, 11,828. That is a 42% death rate for people that enter the hospital with the diagnosis of COVID-19. So I feel that there have been deaths that have occurred from lack of outpatient therapy.
I mean, have you never referred anybody to the hospital for COVID?
Yes, none of them, mostly it was for IV fluids. None of them required ventilator support, and none of them died.
Well, I understand that, but you're not telling us if patient had seen you or somebody like you that we'd have no hospitalizations, are you?
No, I'm just giving you my
Right, and you're
small
not telling
little
us-
numbers.
Right, you're not telling us there'd be no deaths. I think what you...
No, I'm saying that I think that number would be significantly improved. I think the number of people that would go to the hospital would be significantly less, hence the number of deaths would be less.
So I'm going to just get back to my question, because we can only do what we can do. What is it that you would like, what law is it that you're asking us to pass, or are you asking us to pass a law?
I'm not asking you to pass a law. I am here to tell you what I am seeing in the medical community in the state of South Carolina and the frustrations that we are all seeing. Obviously, this has become a huge political thing, so then why am I standing here?
That's what I'm asking you. What is it that you'd like us to do? I mean, obviously, you can educate people, and I join with the senator from Lawrence. I appreciate what you're doing. You're on the front line. And my wife's a doctor. She's seen, I don't know, hundreds of COVID patients, and none of them have been hospitalized either.
Well, good.
Okay?
Then
But-
maybe we need to get together.
Well, maybe, but the point is, that doesn't that doesn't mean that we don't need the hospitals there when we need them.
Oh, no, absolutely not.
Okay.
Oh, that's not the case at all.
Well, I
What I'm
understand.
saying, I'm trying to keep people out of the hospital.
Well, I understand, and so it sounds like you're doing that, and that's wonderful. It just seems to me that there's a complaint out there that doctors can't prescribe what they want to, but every doctor I've asked this morning has told me they can, and there's some complaint that people can't get the medicine, and 100% of your people have gotten their medicine, and the other doctor said 100% of his people had gotten the medicine.
Because those people will not stand in front of this committee and risk their livelihood.
Which people?
My colleagues, my physician, my
Right,
colleague
those are
physicians.
people, though, that you say work for a hospital system.
Correct.
Okay, well, again, they don't have to, that's their choice to work for a hospital system, right?
If you looked at the numbers of independent practitioners across the nation, you'll find that that is going away. I'm a dying breed.
Yeah, I understand. Well, I understand.
So that means that the face of medicine is changing, so there will be fewer and fewer of people like myself that will do their own research and treat
I don't want to
independently.
belabor this, but are you asking us to dictate to the hospitals what their rules ought to be?
I think that, I don't know what this body can do.
Well, we can do a lot. The question is,
Okay.
are you asking us to rewrite the rules for hospital employment? I mean, you think that we, a group of non-medical folks, should be determining what hospitals and what the arrangement hospitals and doctors have with one another is?
Can I help with the question, Mr. Chairman?
Because I think I'm
I think
confused.
we could do that. I don't know.
Well-
Why would we want to?
Would you
Yeah,
allow me?
sure.
Hold on. Senator
Sorry,
from
Mr. Chairman.
Lawrenceburg does
Absolutely.
yield to the senator from Lawrence. Senator from Lawrence.
Thank you, Mr. Chairman. Dr. Hagenbuch, in response to the senator from Orangeburg, would you hearken back to the comments offered initially, very salient comment, and then reiterated by the senator from Beaufort, that anything we can do here within the legislative context to accentuate, amplify, consecrate the relationship between patients and their physicians should be paramount work for us.
Correct.
Without the various factors that the senator from Beaufort listed, whether it be regulators, whether it be examining boards, whether it be pharmacy boards, whether it be corporate pharmacies, corporate hospital systems, accentuating the relationship between the doctor and the physician and the patient is a good admonition for Senator from Orangeburg and the Senator from Lawrence.
Yes, and making sure that these therapeutics are available. Sometimes the pharmacies have to order whatever, and that may take a day or two. So making sure that these medications that are in high demand are available, and the monoclonal antibodies are available earlier rather than later. So I don't know if that's more infusion centers, or I don't understand how this works. But making more.
We've been told that's more of a supply chain issue, that, I mean, when you put the orders in, they get filled. And as you said, sometimes they have to actually be, I don't like to use the word ration, but they at least have to be prioritized when there are not enough doses available, and you understand that and believe in that process. Obviously, if we had all the doses for everything available all the time, that'd be wonderful, but that seems to be a production supply chain issue that's beyond our control.
And the other thing I would say, that if a physician that, let's say, had been employed by a corporatized medicine decided, I want to go out and I want to prescribe XYZ despite what my boss says. So I'm going to quit my job, go out, find a place to practice, get a nurse, get a staff, set up all of the things that it takes to start a practice. That doesn't happen overnight, and as an attorney, I'm sure you're aware of that. So the startup process does take a little time. So it's not like they can turnkey, leave their office, walk out the door, hang their shingle, and start prescribing. It just doesn't work that way. So that's another little
I understand
glitch.
that, but we have a proud history in South Carolina of being a right-to-work state, which means if you don't like what the boss is doing, go get another job. And if the boss doesn't like what you're doing, he's going to tell you to go get another job. That's just the way it is. Okay.
Thank you. Senator Verdin, are you through? I believe Senator Kempson from Charleston has a question.
Yeah, Mr. Chairman, and I appreciate the comments. And maybe we're going to hear from some hospital officials and managing directors of HMOs. But you know, what we've heard is a lot of hearsay evidence with respect to what doctors are being told. And I'm just wishing a doctor who's been told not to prescribe or administer some type of treatment would appear like a man or a woman in a profession and testify to that regard. But be that as it may, that's what we have to rely on, hearsay evidence today. What I'm hoping to hear from the people in charge at these institutions is what incentive would any hospital or any doctor have not to administer protocols, particularly if those therapeutics have been researched, clinical trials have been conducted, and the therapeutics are consistent with medicine or treatment that comports with the doctor's responsibility to not deviate from a certain standard of care. And so I'd be interested in knowing, I don't know who your next presenter is, but I suspect that some of these, and I'm a lawyer, I'm not a doctor, some of these treatments may not be, there may not be clinical trials to use these therapeutics to treat COVID. And if they do, then that opens a whole nother discussion with respect to the patient and the hospital facing potential liability. And so I'm curious who can respond to that line of thought.
Do you have any comments for the senator from Charleston? Okay, I have one question before the senator from Lawrence has a question. You mentioned earlier, and I don't know if you were here for the whole meeting, but
Yes.
I think I mentioned earlier that when Senator Kimbrell was here from Spartanburg, that I've had calls, as he's had calls and contact with doctors who do work, as Senator from Orangeburg said, they work in a hospital system, and they feel like that they're not being able to treat a patient the way they want to. And, we've tried to get those folks to come, but obviously they don't want to be here in person because they're afraid. They've told me they've been told, and I know that's hearsay, but they're fearful of their job. And you brought up a point that they alluded to, but they never came out and told me that yes, they could go get another job, but they're going to have to open up a private practice, get insurance, secure a building, find staff, and I think that makes them nervous. Although that is, to his point, that would be their right or prerogative to do that. Are you aware? Have you seen anything firsthand of those people trying to maybe do what you're doing, but not able to because of who they work for?
No. Not physicians, but nurse practitioners. Pretty much when I have spoken with my colleagues about the therapeutics that I've been doing, they are like, well, I can't do that. I'm not allowed to do that. And that pretty much ends the conversation right there.
So you're in the same boat I am. They're telling you they can't do that, and they're telling me they can't do that, but they're not able to come tell us publicly they're not able to do
Yes,
that.
they're afraid of losing their livelihood.
Okay, thank you. Senator from Lawrence.
Thank you, Mr. Chairman. Dr. Hagenbuch, have I got the right term when I describe a focal point of medical school education practice, shared decision-making?
That's actually a new coined term.
That's new?
Yeah, I kind of like it though.
Well, you described something in your practice where you see a patient in person, hands-on, eyeballs, and then 2 to 3 days later, again, if necessary, and you said you described or you talk about, you consult with the patient the options. Is that
The risk and benefits.
risk and benefit? Is that within the description of shared decision-making?
Yes, sir.
Okay, so we're talking about the patient and the physician. This isn't physician to physician. It's not,
No.
we're not talking about collaborative
No, sir.
practice. Okay. Do you think that COVID, as the COVID pandemic has been, the response to the COVID pandemic has been within the framework of this, as you say, newly coined description of practice, shared decision-making?
I've seen people more interested, they're more read. They come in a lot of times with opinions. Sometimes we agree, sometimes we don't. That's okay, but then also I see people, they just come in and they feel bad and they want to get better.
Okay, they just want to get better. Doc, do something for me.
Yeah.
Does that not harken back to maybe before shared decision-making?
Yes.
I think it's described as a paternal
Yes.
practice of medicine. Just do something, you know better, you know it all?
Yes. That element still is present, yes.
Do you think COVID and the response to COVID fits more the paternal delivery of, the paternalistic delivery of medicine or the shared decision-making?
I think it's both. I think it's 50-50. I think it depends on,
And I know you can't characterize everything.
Yeah, I think it
There's been
depends
so much
on-
broad characterization, but
Right,
I'm just
I
saying
mean,
descriptively.
yeah, I think, I think it depends on the interest and literacy of the patient. I think that has a tremendous amount to do with it. I think those that are more literate and learned, not always, but they're the ones that are going to be more likely to use the internet and, come to me with questions about things that they've seen or read or heard, whereas, a lot of people are just make me better, I feel bad.
Do you think that, say, 5 years ago, 10 years ago, the elevated respect or status, do you think a doctor sat on the same pedestal as a priest or a minister?
When,
10 years
10
ago?
years ago? I don't think of myself in that fashion, so I guess I wouldn't know.
Think about the professions in the world in your life that you, all right.
People
so
like nurses
let
better
me
than
throw
doctors.
the lawyers in
Set
with you over
aside
there.
lawyers, 'cause
Let
we
me throw
know
him
we'll-
in
Okay,
there.
y'all are way down here.
Well, I know where I am, Dr. Hagenbuch, as a politician. I know where I am. It's not fun anymore. This is work that we have to feel compelled to. I used to say you had to have a combination of a little bit of big heart and big head. Well, the big head is gone. Again, back to the urgency of our constituents and why we're here. So if the medical profession has been undermined, do you think that we as politicians possibly meddling in business that we have no business? You think the lowly politician has effectively knocked a highly elevated and regarded medical community off their pedestal? Or has the medical community themselves been as great or maybe greater a contributing factor for the lack of trust that seems to be manifesting?
I think there are a lot of physicians that have become politicized. I think it's twofold. I don't think it's one way or the other. I think politics has gotten involved in it, but there are also physicians are people too, and they have their own opinions and politics as well, and they've allowed that to become part of it in addition. So they'll, and I'll say, for example, they may just look at one or two sources. They may limit the sources that they view because this is what they know, this is what they're comfortable with, this is what they've been taught in residency and fellowships, or you can open the door and look around and try other things. You know, I'll use an example. In my limited career, ibuprofen, back to my pediatric colleagues, I don't think y'all are quite as old as I am, but it was contraindicated to give to children under the age of 18 when I was in residency. Now it's over the counter. So there's a lot of things that change, but if we continue the dogma and don't look past the dogma, we're never going to progress. And there will be people in every field that stick with the dogma, and those people are important. There will be people that look past the dogma, and those people are important as well.
Dr. Hagenbuch, you've demonstrated your appeal from the citizens of South Carolina at large when you told me that you're treating people from all over South Carolina. I can't help it, but I want to empower my constituents and the constituents of everyone in this room that feel confident through shared decision-making, and I would never look down my nose at their ability to help determine what is in their best interest. I want to get to the point where you're not carrying an 80-patient load.
Me too.
From patients all over South Carolina. I want them to stop 5 miles from the house and find their Dr. Hagenbuch at home. And if I can do it with the help and the collaboration of my colleagues, I'm going to do everything in my power to empower those physicians and those patients to get to the point of shared decision-making without interference, but with the blessing and the assist. And that includes everybody from boards of medical examiners, national certification boards, federal agencies. I'm making that commitment.
Thank you. Thank you. Whatever you can do to help.
Thank you. And thank you, Dr. Hagenbuch.
Thank you.
I'm going to wait before I call the next person up. Staff has to make an adjustment.